Thanks very much, everybody. Can you hear me okay?
Yeah, we can hear you.
Right. It's a great pleasure to be here with everybody and to be in the UK. People keep saying, why did you come? I can 100% tell you that the weather has been lovely and mild, but nobody comes to England for the weather. It is my pleasure to share with you the learnings that we've had uh, and the work that we've done in really building up a program of work and embedding that into education practice at Griffith University. So just a little bit of background. We started a Bachelor of Midwifery in 2010, and we always wanted to design it to really embrace all the best principles and practices of contemporary learning and teaching, theory and evidence. And we sort of did that really. So just to move us along a little bit. Okay. All right. That's me. I'm Professor at Coventry University in a joint appointment with University Hospital of Coventry and Warwickshire, and I'm still Professor Emeritus at Griffith University. So I guess I wanted to talk to you today about learning woman-centered care and evidence-based care. So we're all very familiar with best available evidence about models of care. Women and their babies do better, excuse me, when they have continuity of care, a known midwife across pregnancy, labour and birth, and postpartum. And we also know that that relationship-based care really gives midwives, student midwives, the very best opportunity to really get a strong sense of woman-centered care. So I'm going to talk to you about sort of three big developments out of all of the things we've done that are really focused around the clinical practicum component of the students' education program. And the first one is about curriculum design to foster relationship-based care. The second one is about evaluating clinical practice experience, and we've used and designed a special tool called Midstep, but there's characteristics of that I think are important to the audience tonight. And we've really done a whole body of work, and that's still ongoing, in fact, about the contribution that students make to clinical care and outcomes for women and their babies. Just a little bit about a background about Australia. So I know you've just got your new standards, your new midwifery education standards here in the UK. In Australia for some years now, pioneered really by ACM and a group of midwifery leaders, we introduced the idea that student midwives should provide continuity of midwifery care, continuity of student midwife care to a number of women throughout their education program. So the current regulations say that pre-registration midwifery students are required to engage in a minimum of 10 continuity of care experiences. And in the interest of time tonight, I won't talk about all the requirements in that, but they have to do a certain number of antenatal visits, be there for labour and birth, and be there postnatally for a certain number of visits. So they don't have to do all of the care. And of course, they're under supervision of a registered health professional, just about always a midwife. Although in Australia, especially if the woman's receiving fragmented care, she may receive some of her care from a GP, particularly, for instance, a 6-week postnatal visit. She may receive some of her antenatal visits at a GP as well. And the student midwife can certainly go along to that and be supervised by a GP. But most student midwives don't choose that option. And, the most common one would be that 6-week postnatal GP visit if the woman would have with the student midwife. So that's just the nuts and bolts of it without going into a whole lot of detail, because really I want to talk about the enabling of this through by design. So I think it really starts with thinking about how you're going to design your curriculum. And if you come to grips with quite quickly the beneficial outcomes of continuity of care experience for both the students and the women, it's a unbelievably valuable experience for student midwives, so much so that our Nordic colleagues have got me speaking to the Swedish midwives have got me speaking to their colleagues later on this month about continuity of care experiences for student midwives, in part because we've got formal ways that we've assessed this throughout our education-related research, but we also talk to all our students, and you'll say to the students, how's that going for you? And they'll say, it's by far the hardest thing to fit in on top of assignments, shifts, all their other clinical requirements, families, everything, travel. They think it's the hardest thing to do, but they also, by a country mile, think it's the most valuable thing to do, that they really felt they learned how to be a midwife by doing this. The continuity of care experience builds mutual support and nurturing between the woman and the students, and it fosters clinical confidence, resilience, and influences their career goals. This is all work that we've done. I'm only going to talk about some of the papers tonight over the years, but I think that notion of fostering clinical confidence is quite important, because the students will say to us things like, when the woman was in fragmented care, e.g., she's no continuity, she might have seen a different midwife each time antenatally, or a different health practitioner. Same again for labour and birth, shift-based care, and same again postnatally. The student, especially as they matured as students, by the time they were in third year, they really started to realise that the only continuity that was being provided by them, and that they had special insights and knowledge into the woman's whole journey from the health service point of view, but also, and so importantly, from the woman's point of view. So they would be able to pipe up and say, oh no, she had those tests done last time she was here. You just have to dig around for them. They definitely were done. So she also just knew about the woman's whole journey, not just, I don't mean to belittle that, but not just the woman's perspective of that journey. And that meant she had unique insights to share. So as they were nearing the end of their third year, they felt more and more confident about their clinical skills, about their knowledge of the system, about their knowledge of the woman, but also, and I think this was a massive learning, about the gaps in the system and how women can fall through the gaps. And that different care providers at different visits aren't necessarily building that whole clinical picture of pregnancy, labour and birth, and that postnatal period. For us, it was very important to make sure we had curriculum coherence, both structural and conceptual elements that were focused on continuity of care experiences. So really, we designed the curriculum to enable learnings at all levels around continuity of care. So we wanted attitude development, knowledge, skills, know-how about how this all worked, because that's what we're really preparing these students for, is that ability to both work in continuity care models, but also be part of that picture of driving reform towards universal access to continuity of care for women and their babies. The education standards, so we concluded that the education standards that preference continuity of care experience as the optimal clinical education model need to have measurable learning outcomes, and you need to align to a whole of program philosophy and program learning outcomes, as all of that is required. So for us, we do a range of structural and process things. For instance, if a student's required to come to an exam, but she's got a woman in labour, then she just rings up or emails and says, I've got a woman in labour, and she goes to the woman in labour, because you can't profess woman-centered care. You can't profess that the woman comes first, and then in fact ask the student to put the exam first and the woman second. So we would always we'd just make arrangements for that. Should attend the woman for labour and birth, should go home and have plenty of rest, and 2 or 3 days later should do exam. It's just once you get those principles right and the philosophy right, then you design around that. And this slide just shows you the values, the meta values that underpin our curriculum, and you can see woman-centered is front and centre. Birth is normal, that it's a social model of care. Continuity of care is important, critical, that it needs to be culturally safe and respectful care. That midwifery is political and need to be critically reflexive. So we use this in the design and delivery, and we come back to this when we're unsure about what the next steps might be or should be. So I'm going to move on now. So I've talked about curriculum. I'm now going to talk about Midstep, which is about evaluating students' clinical experience. And for any educators that are on board today, I'd really like you to think about this. If you're in a position to influence standards nationally, I'd really like you to think about having a look at this tool in particular for midwifery. there's a big move in Australia to have, if you like, a standardized clinical evaluation tool for all of the health disciplines. And I can see, obviously, that's got some merits, but we developed Midstep and we've been using it now at Griffith for a number of years. We use it year on year. There are now a range of other universities throughout Australia and some in New Zealand that are also evaluating the students' clinical experience as a clinical component of their education program using Midstep. It has 16 items for a clinical learning environment scale and 10 items for a midwife preceptor scale. And both of those have two subscales, the skill development subscale, like for instance, it would ask about, how well did your preceptor facilitate your skill development in something or other. But it also, and I think this is the defining characteristic of Midstep, it has questions that relate specifically to support in the learning environment and with the preceptor around the development of a philosophy of midwifery practice. So that would say, did the clinical learning environment foster your ability to provide woman-centered care? Did the clinical learning environment foster your ability to critically think or to raise clinical questions? So it has a range of questions around skill development and the philosophy of midwifery practice, because what we've really got to say to ourselves is, are we placing students and enabling their experiences, their clinical experiences, that really build up them as a midwife, not just as any old, and I don't mean this negatively either, they're not a generic health worker. Midwives bring a certain sort of skills, but they also bring with that a philosophy of midwifery that I think is critical to what Anna was talking about before. That is our connection to purpose. Midwives come in and stay being midwives because they love practicing midwifery. They're not trying to be a generic healthcare worker, even a generic healthcare worker that might, for instance, like a GP, have some times where they work with pregnant women or postpartum women or birthing women. And then we use Midstep to, we embed it within a broader clinical evaluation survey because we want other information as well. We want to know what year the student's in. We want to know predominantly which model she's been in, if she's been in a continuity care model or a fragmented shift-based model for the last 6 months. We've got a range of other questions that we want to ask the student. So it's within it, which practice site is she at, for instance? Has she worked predominantly with the one preceptor for that entire time? Those sorts of questions, they help give us the other variables for us to use in analysing the data. We use this data to inform decision-making about potential improvements to the clinical program. We write an annual report based on these data. It's quite a comprehensive report. It's a long report. And we give the report to each of our practice sites. Some of our practice sites are private midwifery practices, but most of them are hospitals. Toowoomba Hospital, Gold Coast Hospital, they all get the report. They all get the report that also compares the cohort of students that were at their service with the cohorts of students that were at other services, so they can see how they're going as a health service in providing a quality clinical learning environment for the student midwives, and they can benchmark that against neighbouring services fundamentally. And they really value that as well. And that's really helped them inform their discussions all within health, if you know what I mean. So, you'll have Logan Hospital and Gold Coast Hospital and Toowoomba Hospital all talking together about things that they did well, the things that they want to improve on. And they can look to their sister organisations to say, you clearly really nailed that. We didn't do so well on that. What are you doing? And how do we bring our results up to your level? So there's been terrific learning in it. And even at its most basest, at a very sort of basic, not so charitable level, health services can be quite competitive. They just don't like some other hospital doing a better job of providing a student learning environment than their hospital. So one way or another, whether it's a super positive, caring, collaborative thing, or whether it's a slightly negative, minorly petty, competitive thing, nevertheless, that notion of giving people data about how their institution is performing in providing quality clinical learning experiences to students does make them improve. And we have seen that over time, improvements in the clinical learning environment. especially in areas where there was a shortfall. So we can look across scales. We look at the student, across the scales, the midwifery student rate continuity of care models more highly. So one of the things we measure is what model of care were you in, like working in, and students really value continuity of midwifery care. Okay, now keep me right and interrupt me if you think I'm going too long. I think I'll be right. Okay, outcomes for women and their babies. The other thing we've done is we've created this clinical e-portfolio, and the students record all of their things in there, all of their clinical learning in there. They do holistic reflection. They report on their mandatory experiences. There's a range of skill development tools embedded within it. They have their twice yearly AMSAT, we call it, their overarching clinical assessment tool. But they also record all their clinical continuity of care experiences that they provide. And the portfolio is called Maggie, Midwifery at Griffith in something or other. And it's just a platform that we've customized to our needs. One of the things we've built into that now is that when the student midwife reports the data that the woman who she's providing continuity of care with has had the baby, 6 weeks later, that woman gets automatically sent a survey, which includes two standardized scales in it, one with satisfaction and one with respect. And the women fill that out just with a link. They send it all back. It comes back in to the student's clinical portfolio. And then the student has a reflective opportunity to think about the feedback that she's received about the care that she's provided. And women, it's not 100%, but women overall and the vast majority report very, very positive experiences from having a student midwife provide continuity of midwifery care. The other clever thing I think that we did is they record certain clinical outcomes. So we're careful about the clinical outcomes. We wanted the students to record in that. But then we've got thousands of recorded cases of women with continuity of care by student midwife. And what we did is we analysed that data for women who'd had continuity of care by student, but not in a continuity of care model, because that would stuff up the data. And the clinical outcomes for the women who had a student when the woman was going in through a fragmented, shift-based model of care, were as good or better on the 12 variables that we measured. They were not worse on any, and there was a positive reduction. There was less third and fourth degree tears for women who had a student midwife, and less episiotomy and reduced smoking compared to statewide and national perinatal data. So we're not claiming cause and effect, but it is interesting. And in some of our continuity midwifery care programs, we definitely have had things like reduced smoking. So we'd be interested to follow up what that really looked like. And we concluded that student midwives providing continuity care should be offered as soon as possible in pregnancy because they contribute positively to care and that their contribution should be acknowledged. I'm going to leave all these references here, but they're just references to the studies I've referred to along the journey. And really that's it for me. But I guess what I'm trying to say is primacy, acknowledging and providing primacy of the continuity of care experience provided by students, regardless of the model of care that the woman is in, seems to be critical to teaching the next generation of midwives to be able to provide evidence-based woman-centered care. And I think the only other thing I'd say is that I think there's plenty of room to make this the model, all continuity of midwifery care for student midwives. And some universities in Australia are moving towards that, where they might then, in fact, do some shift-based care, say particularly on a postnatal ward, just so they understand how that all works. But I think there's plenty of room to just turn the whole thing on the head and stop doing business as usual and design it for how we want it to be in the future.
Thanks for watching this video from the Maternity and Midwifery Forum. For more expert opinion and analysis, hit the button below to subscribe.